Okay, thank you very much, and then welcome back for this afternoon session. We are going to see about study designs. So we'll see the further extensions or further varieties of different epidemiological study designs that you have already learned in your fundamental epidemiology course. So as you know from your basic epidemiology course, the study design is defined as the process that guides the researcher on how to collect data and how to analyze and interpret the observed or the collected data. So simply this is a general framework or a logical model that guides the investigator in the various stages of the research. If you know the study design that you are going to use for your research, then you'll be clear on how to collect the data. For example, if you choose a case control study design, then the author or the researcher will have a clear map in his mind on how the data should be collected for the case control study design, how the study participants will be selected, and how the data will be analyzed, the method of data analysis for case control study design, and how the interpretation of the analysis would be made for that specific study design will be clear for the researcher once the study design is chosen. So that is why study design is the process that guides the researcher on how to collect the data, on how to analyze the data, and on how to interpret the data. If you choose a prospective course study design, then it will be clear for you at the very beginning how the data is going to be collected, because the data collection for course study design is different from the data collection for case control study design and different from the data collection for cross-sectional study design and the way of data collection for the experimental study design. So the way of data collection for each of the study design is different, the way of study participant selection, the way of data analysis method, and the way of interpretation of the analyzed result is different in different study designs. So that is why study design is the general process that guides the researcher on how to collect the data, on how to analyze the data, and on how to interpret the data. So in general, it is a logical framework or a logical model that guides the investigator or the researcher in the various stages of the research work. So that is the definition for study design. Because the various stages of a study design will depend on the design that you have already selected. So that is the way we need to just define study designs. So this is simply arrangement of conditions for the collection and analysis of data. As I have said before, if you choose one specific study design, so that arrangement of the conditions, that means the way of data collection, the way of data analysis, the way of interpretation of the data, the way of study participant selection will be arranged in line with the characteristics of the study design that you have already chosen. So simply we can say that this is an arrangement of conditions for the collection and analysis of the data. That is the definition for study design. So this is the overall structure of the study. You see, a study design will guide all the various stages of your research work. Once you have chosen the study design, the variety of stages that we need to follow will be shaped by the study design that you have selected. So the various stages of the research work will be guided or managed or shaped by the study design that we have selected. Because in order to match the objective of the study according to the chosen study design, the stages should be in line with the characteristics or the nature of the study designs that have been chosen. So that is why study designs are defined in such a way. Okay, therefore you can say in either of these four ways of explanation or just way of understanding of the study design. Okay, you see, in doing research, the first step that we are going to do is developing a hypothesis. The first thing that should come to your mind is a research question. You need to have a question first. And to have a question, there should be a problem that existed in the life of the community, you know. There should be a problem that exists. And it has been said that the existence of a problem is the driving force behind doing research, you know. Unless and otherwise, there is no existence of a problem, there is no need to do a research. So the existence of a problem is the driving force behind doing any research. In our country, there is a proverb which has been said in Amharic, ችግር ብልሃትን ይፈጥራል. So that the existence of a problem is an opening door for developing a solution. So that means the existence of a problem is the driving force behind doing a research. So the existence of a problem is the source for doing research. Okay, I think someone is asking to join. Okay. Okay, so what I want to say here for you is, yeah. So what I want to say here for you is that before developing any research hypothesis, there should be a research question. And in order to just to develop a research question, there should be existence of a problem, you know, because the existence of a problem is the source for just having a question. If a problem exists, then we start to ask a question. So from that existence of a problem, there will be just formulation of a research question. From the formulated research question, then we are going to develop a research hypothesis. Okay. Now, once we have developed the hypothesis, or once the hypothesis is created, after developing the hypothesis, the first thing to be considered is to decide how best to test for a possible link between the exposure and the disease. What is the best approach to test that hypothesis? So, in order to just test the developed hypothesis and in order to just whether prove or disprove the hypothesis, which study design will be the best appropriate? So that after creation of the hypothesis, the next thing that we need to consider is the appropriate study design for testing the already developed hypothesis. So once we have developed the hypothesis, the next thing that we need to consider is how best it will be good for us to test the hypothesis. Which study design will be well appropriate for testing the hypothesis that we have already developed. So the main tool used by the epidemiologists to determine potential connection is by the use of a study design. So that choosing a study design is dependent upon the type of hypothesis that has been developed. So the hypothesis that is already developed will guide us which study design will be appropriate for testing that specific hypothesis. And actually there are additional criteria on how to select study design, and that will be just the issue of your research methodology course. In addition to the hypothesis that has been developed, in order to choose the study design under consideration, there are again other additional criteria that we need to consider for choosing the study design. And that further addition of further criteria will be the objective of your research methodology course, which will be given maybe at the end of your courses, you know. So one of the criteria of choosing a study design here I want to tell you is that the hypothesis that we have already developed. So there should be a right study design should be chosen to correctly test the hypotheses that have been developed. Okay, so there are also a variety of study designs or methodologies are utilized to conduct epidemiological investigation or to just test whether there is a correct specification of a hypothesis or not. So that the types of study designs that is selected depend on the research question to be investigated, the type of the data available to answer the question, the time frame, that is past history or the current data or future data, and the feasibility in terms of cost, in terms of time allotted or allocated for data collection, in terms of staff and technical resources to carry out the study, in short, and ethical considerations. So these things will be just considered in selection of the study design. And the summary of these criteria will be elaborated more in your research methodology course. But in short, these are some of most important typical characteristics that we need to consider in choosing a study design. The research question, that is specifically the research hypothesis, the type of the data that is needed to answer the question, and the time frame. That means the data, whether it is a past or maybe past history data, or a current data, or maybe future data, or a follow-up data nature. And the feasibility in terms of the listed criteria here under the bracket. And finally, ethical consideration. Is there any ethical challenge or not in doing the research, the selected research question? So these are a summary of the criteria that we need to consider in choosing a study design, and this will be more elaborated in your research methodology course. So, as you have already learned in your basic or fundamental epidemiology course, we classify study designs in such a way as a descriptive and analytic research. And as you know, the descriptive types of epidemiological study designs are more of concerned with knowing the magnitude of a certain health condition and its distribution in terms of time, place, and person, most of which are used for planning for healthcare services, and for knowing the magnitude or the prevalence of a certain health condition in a certain place at a specific point in time and geographical location. And again, under this, we'll have a case report, a case series, ecological and cross-sectional study designs. The analytical study designs will be just as an observational study designs or experimental study designs. And again, from the observational, we'll have a core study design, case control, and cross-sectional. And actually, the descriptive cross-sectional study design lacks the analytic component. There is only descriptive result, description of the magnitude of the health conditions that we are going to study, and the distribution of the problem or the health condition by time, place, and person. That is the issue of descriptive cross-sectional study design. But the analytical component of cross-sectional study design will add up analytical result. That means there will be just a measure of association in terms of either odds ratio by doing any type of regression methods. So there will be a calculation of odds ratio in order to just measure whether there is an association between suspected exposure with that of the outcome variable. So that is the analytical component of cross-sectional study design. And experimental study design, broadly we classify them as therapeutic trial and preventive trial. But there are further extensions, that we will see in detail in the coming weeks. These are not the only classification of experimental study design. There are a number of varieties of experimental study design. There are a number of varieties of case control study design. We will have a number of varieties of cross-sectional study design. We will have a number of varieties of ecological study designs. This will be just elaborated more, maybe starting from today in the coming weeks. And actually, the basic difference in observational study designs and that of experimental study design should be clear for us. In the case of observational study designs, the agent under investigation is found to be, or the individuals under the study are found to be exposed by themselves for the factor under consideration. But in the case of experimental study design, the factor under consideration or the agent is always intentionally controlled or administered by the investigator. The investigator will administer an agent or exposure for either of the comparison group in the case of experimental study design. So the agent, the location or the randomization and the follow-up of the study participants is always under the control of the investigator in the case of experimental study design, but not in the case of observational studies. Okay, maybe we can classify the study designs in such a way, again, from the usual way of classification. The one which is very special is we can classify research designs as study designs as non-experimental studies or observational studies and experimental studies, Because as I have said before, in experimental studies, there is always manipulation of the agent under investigation. And then the experimental studies could be either randomized controlled trials, that is RCT, which is a gold standard one, and non-randomized clinical trials, or simply quasi-experimental trials. In the case of quasi-experimental trial or non-randomized trial, there is a comparison group, there is a treatment group. But allocation to either of the groups is not by random allocation. There is no random allocation in the case of quasi-experimental study. What it makes to be similar with the RCT is there is a comparison group. But what it makes different from the RCT is there is no random allocation of the study participants to either of the group in the case of quasi-experimental or non-randomized controlled trials. Okay. In the case of non-experimental or observational study designs, this should be again classified as a population-based study and individual-based studies. As you know, individual-based studies could be either classified as descriptive and analytic. The descriptive ones are case report and case series, and the analytic one, that is individual-based observational studies, which are analytical, are the cross-sectional study, the case control study, and the cohort study. But the population-based observational studies are ecological study design and a survey or a health survey, like DHS reports or maybe DSS sites. There are demographic and surveillance sites according to, maybe there are different DSS sites in Wollo University, Bahar University, Gondar University, Arba Minch. There are a number of universities in our country having DSS sites, So such types of sites are said to be health surveys or surveillance sites. So these are the surveillance sites could be taken as health survey, which are population-based, and ecological studies again under the population-based observational studies. So we can classify, research could be broadly classified into non-experimental and experimental. Okay. So now, as I have said before, the main difference between experimental and observational study is the control that the researcher may have over the study participants, and the methods and the procedures and the exposure. Always in experimental study design, the investigator have the right to control on how to administer the agent for the study participants, and the method and the procedure and administering the exposure is always under the control of the investigator in the case of experimental studies, but not in observational studies. In an experimental study, the researcher can control some of the client's entire data intake. If you are just planning to do a supplement for just maybe for preventive or treatment effectiveness of a certain dietary supplement for a specific disease. So the client's entire data intake will be just controlled by the investigator. So one group should be just taken as a specific type of food, and another group will be just given as another type of supplement, So that is, the investigator will have the right to control the study participants under the study. But in an observational study, the researcher does not intervene in or manipulate the client's exposure. Rather, the study participants will be found to be exposed for the exposure under investigation by themselves. For example, if you are going to compare whether there's an association between alcohol utilization or alcohol drinking with that of liver cancer, you are not going to order individuals to drink alcohol. Rather, you will go for within the community to just identify individuals who are drinking alcohol, taken as exposed group, and individuals who did not drink alcohol will be taken as non-exposed groups. So then you will follow them until a certain period of time. So in such a way, observational studies will be conducted. Other than this, the investigator will not have the right to just control the exposure under investigation. So before just going into the different varieties or subvarieties of study designs, we need to just have a clear understanding of general features of study designs. The one feature is in terms of the directionality of study designs. Directionality of the study design should be clear for us. So directionality of the study designs refers to when the exposure variable is observed relative in time to when the health outcome is observed. That means, does the exposure comes first or does the outcome comes first? Which comes first and which comes next? Directionality of the study design is the relationship of the time of initiation of the exposure relative to the outcome of interest that we are going to measure. So in terms of this directionality of the study design, that means in relation to the exposure variable without of the health outcome, there can be a forward type of study design, a backward type of study design, and non-directional study design. So this directionality of the study design affects the researcher's ability to distinguish antecedent from consequent. That means it will just enable the researcher to just have a clear understanding of the temporal relationship of the cause and the agent with that of the outcome. Which comes first and which comes next could be appreciated, especially in the case of forward study designs, but not possible in backward and in non-directional study designs. For example, if we use a cross-sectional study design, we cannot ascertain the temporal relationship of the exposure with the disease. Which comes first and which comes next cannot be confirmed or ascertained by the use of a non-directional study design, that is a cross-sectional study design. So knowing the directionality of the study designs will enable the researcher to distinguish whether there is a temporal relationship or which comes first and which comes next could be confirmed or which could not be confirmed in choosing the study design. So we need to be clear with the directionality of the study designs. Okay, in a study with forward directionality, the investigator starts by determining the exposure status. We first identify exposed individuals and non-exposed individuals. So we have already know that exposure comes first, and then we'll follow the study population till a certain period of time. So that we know that the disease comes next. So we can ascertain or we can be sure that a cause comes first and the outcome comes next. So we can be sure there is a cause and effect relationship in the case of forward directionality study designs, whether it is a forward prospective study design or maybe experimental study design. So cohort studies and clinical trials always have a forward directionality. And actually, cohort study design, whether it is a retrospective or prospective, it is always forward directionality. Because we start in whether it is a retrospective or prospective cohort, what we initiate the study is by identification of exposed and non-exposed individuals, For example, if your study design is a prospective cohort, you identify exposed individuals, E+, and non-exposed individuals, E-. And then you will follow them until they develop the disease in a certain period of time, forward directionality. But if your study design is a retrospective cohort, similarly, you will identify the exposed individuals, E+, and then the non-exposed individuals, E-. But now this time you'll go back to their back history of the disease status. Do these individuals have developed the disease in their past history? Even though we go back to assess their disease status from medical records or maybe by taking history, we have started identification of the individuals by being exposed and non-exposed. So since we have started by identification of the exposure status and go back to assess their disease status, we can just indirectly be sure that the exposure comes first and the disease comes next. So it is always forward directionality. Okay, I thought someone was asking, but no one is there. So let's continue. Okay, you can have a look at on this diagrammatic representation, the timing that the initiation of the study is started over here, and then we will identify the exposed individuals as being exposed yes and non-exposed no. And then we'll follow these two groups, whether they will develop the outcome of interest, that is a disease or not. That is under question mark. Some of the individuals exposed in the exposed group will develop the disease, and some of them will not develop the disease, D plus and D minus. And from the non-exposed group again, some of the individuals will develop the disease, D plus, and some of the individuals will not develop the disease, non-diseased. So this is a feature of course study designs and clinical trials. So such study designs are always forward in their directionality. That is relative to the initiation of the exposure with that of the outcome of interest, the disease status. Okay, in the backward design, the investigator selects subjects on the basis of whether or not they have the health outcome of interest, the disease, and then obtain information about their previous exposure. We'll identify individuals as being diseased and non-diseased, as you know in the case control study design. At the initiation of the study, we identify individuals as being diseased and non-diseased, D plus and D minus. And then we'll go back to assess their back history of exposure status. That is backward directionality in the case of case control study design. Okay, so here is a graph which shows what I've already done. Here are individuals which will be selected based on their disease status. Being diseased as yes and non-diseased as no. And then we'll go back to their back history of exposure status. Do this group of individuals were exposed for the exposure or not? Will be just the feature of case control study design. That is a general directionality of case control study design. And then in the non-directional study design, which is the feature of cross-sectional study design, the investigator observes both the study factor, the exposure, and the outcome simultaneously. We will measure both the factor, that is the exposure, and the disease status simultaneously at a point in time, so that neither variable may be uniquely identified as occurring first. So which comes first and which comes next cannot be ascertained in the non-directional study designs. That is the nature of a cross-sectional study design that is said to be non-directional. So that is the problem of cross-sectional study design. We cannot just ascertain the temporal relationship between the exposure and that of the disease. And you are familiar with the egg and chicken dilemma of cross-sectional study design. Which comes first, the chicken or the egg? Or the egg or the chicken? It cannot be just ascertained, you know, because while the hen is giving the egg, within the egg there is a chicken. So that, but after maybe 21 days of just having a hot area, the chicken will be just breaking out from the egg. Even though it takes time to just go out of the yolk, there was a chicken within the egg. So which comes next and which comes first will be just cannot be ascertained in the case of cross-sectional study design, because we have assessed both the exposure and the disease status simultaneously at a point in time. That is said to be non-directional study design. So we'll have forward directionality, backward directionality, and non-directional study designs generally. So here is an elaboration with a graphical representation So there's a timing over here. We started assessing the exposure status and the disease status at a point in time simultaneously. So there is no direction, whether it is backward or forward. Okay, the first thing that we have seen is directionality of the studies. Especially the directionality is determined based on the initiation of the exposure relative to the outcome of interest or the disease. The next issue is timing of the study design. And I think someone is asking to join. Okay, I don't know, okay. Okay, the next thing that we need to consider is timing of study designs. Timing concerns the question of whether the health outcome of interest has already occurred before the study actually begins. Now, directionality was based upon the relation of the exposure with the disease status. But timing of the study is concerned with the relation of the occurrence of the disease when the study is initiated, Does the outcome of interest have occurred at the initiation of the study or not? That is the timing of the study. But directionality of the study is the initiation of the exposure with that of the disease status. But in the case of timing of the study, this is the initiation of the study relative to the occurrence of the outcome. Relative to the outcome or the disease status. So if the health outcome has occurred before the study is initiated, then the timing is retrospective. If at the initiation of the study, if the outcome is already occurred, then the study will be retrospective. Because since the outcome is already occurred, we'll retrospectively assess the disease status. Because it has already occurred at the initiation of the study. So that is said to be a retrospective, which is the feature of a case control study design, which is retrospective always. So we do have a graphical representation over here. The study is commencing or initiated over here. But at the initiation of the study, we know that the disease is already happened before. So if the disease status has already happened, then what we are going to do is we identify the individuals being diseased and non-diseased, and then we'll go for their back history of exposure status. This is a feature of retrospective core study design and a case control study design. In case control study design, we identify diseased and non-diseased individuals, and then we'll go back to assess their back history of exposure. And in the case of retrospective core study design, we identify exposed and non-exposed individuals, A plus and A minus, and then we'll go back to assess their back history of disease status. Why? Because the disease has already occurred. So that case control study designs and retrospective core study design are retrospective in timing, not in directionality. In directionality, retrospective core study design is always forward directionality. But in timing of the study design, a retrospective study design is a retrospective, like that of case control study design. But in terms of directionality, a retrospective core study design is forward directionality. But in terms of timing of the study design, it is retrospective because the disease has already occurred at the initiation of the study. So we should be clear of in terms of timing of the study design and directionality of the study design. It should be clear for us. Okay, on the other hand, the health outcome occurs after the onset of the study. If the outcome of interest or if the disease is occurred after the initiation of the study, then according to timing, the study design is prospective. That is the feature of clinical studies or clinical trials and prospective core study design. So the timing of a study can have important implication for the quality of the data, If the disease does not occur at the initiation of the study, we can be sure that the factor is really a causative agent for the disease. Because we can be sure the exposure occurred first and the disease comes next. So we can confirm cause and effect relationship between the factor and the disease. Okay, let's have a look on the features of these clinical trials and that of prospective course study design. There's the timing of or the initiation of the study over here. We identify the exposure status. There's the exposure which already occurred before, and we initiated the study here. But as the initiation of the study, the disease does not occur. The outcome does not have occurred yet. So we need to follow, or we need to wait for some time until the outcome happens or until they develop the disease. So that is a prospective nature of study designs in terms of timing. Timing is in relation to the occurrence of the disease relative to the initiation of the study. Okay, so now let's come back to the descriptions or elaborations of the classification of the study designs that you have already known. The descriptive study designs are concerned with the distribution of the disease, so that they are useful for location of resource. This is a summary that you have already learned. So they are important for hypothesis generation, you know. Hypothesis will be generated from a descriptive results by having a magnitude of a problem, a prevalence, the number of individuals with a specific health condition. If that is beyond the expected frequency, then we'll start asking the question why the usual frequency or prevalence of a disease is higher than the usual prevalence. The question will be arising. So that based on that question, we'll develop a hypothesis. So descriptive study designs will be just used for resource allocation, which are most of the time an input for healthcare resource allocation and healthcare planning, you know. Any hospital, any health center, or any health facility will develop their healthcare planning for each of the years based upon the descriptive study results, you know. So they are important for resource allocation and for hypothesis generation. So they are less time consuming and less expensive, that you know. They are commonly used. So the most common research design used in nutritional epidemiology and descriptive studies is most of the time. These descriptive types of studies are more of applicable in nutritional epidemiology because there are byproducts, processed nutritional values, processing, especially in the industry. There are a number of issues that we need to consider. So descriptive studies are considered less scientifically rigorous than analytic studies. The drawback is we cannot be sure whether there is an association between a factor with that of the disease, even though they are important for developing a hypothesis, you know. However, it is important to emphasize that all study designs have a place in the hierarchy of research methodology, you know. There is no superior study design and there is no inferior study design, because all of the study designs, they do have their own place in the hierarchy of the hierarchy of research methodology, you know. Without having a descriptive data, no one can do analytic research, you know. So we cannot say that analytic study designs are superior than descriptive study designs, because unless and otherwise we do have descriptive data, we cannot do analytic analytic results. So that we cannot say that the analytic one is superior than the descriptive one. So each and every type of the study design have their own place in the hierarchy of evidence generation. Sorry. For example, descriptive research often provides valuable information for generating hypotheses. Even you see, the data obtained from the descriptive result, study designs will be used for generating a hypothesis. Without generating a hypothesis, one cannot test a hypothesis with analytic study designs. So for analytic study designs, to have or to test a hypothesis, there should be a descriptive design which produces the descriptive result, which will be used for generating a hypothesis. So that is very important, which can then be tested using the analytic study designs. So descriptive study designs are very important for developing a hypothesis. So then after the developed hypothesis based on the descriptive result will be tested by the analytic one. But without having the descriptive study designs, the descriptive results, the analytic study designs cannot do anything. So every type of study design are really very crucial. So descriptive studies also tell us about the current status of a problem. What is the current level or magnitude or prevalence of a certain health condition in a certain population? Could be ascertained by the use of descriptive results, Analytic results cannot tell us the current level or magnitude of a certain health condition. For example, if a cross-sectional study design could be done to identify what percentage of the population is anemic, what percentage of a population is deficient in vitamin D, what percentage of a population is being a smoker, what percentage of a population is doing regularly exercise, and so forth. What percentage of a population is positive for HIV, positive for tuberculosis, the mortality prevalence related with CVD, cardiovascular disease, maybe any different medical conditions. All these are made possible by the use of descriptive study designs. So this process measures the prevalence of a disease generally. Okay, the same or similar examples again given in the PowerPoint, but in the analytical study designs, most of the time they focus on the determinants or causes of a disease, which are again very important. But in order to know the determinants or the causes of a disease, we need to have a descriptive result. We need to have a figure, a number. Without having a number, without having a descriptive result, one cannot ascertain whether X is a cause for Y. Even though analytic study designs are focusing on knowing the determinants or the causative agents of a disease, it cannot be made possible without descriptive result. So that these analytic study designs, as you know, are used for testing a hypothesis. So the major distinguishing features of analytic studies is always the use of a comparison group. That is maybe a control. So there will be always exposed and non-exposed group, case and control group. So there is always a comparison group in analytical study designs. Whether it is analytical cross-sectional study design, case, control, cohort, experimental, whatever. There is always a comparison group. Unless and otherwise we do have a comparison group, one cannot do or one cannot determine the causative agents, So analytic study designs are considered better for determining whether certain factors may be a potential cause or a potential protective factor for a certain disease. So that whether X is a cause for Y or an agent is protective for a certain disease could be made possible by the use of analytical study designs. So with the exception of the case control study, analytic studies follow populations over time, which is considered a key factor in determining a potential causal link between exposure and disease. Okay, so categories of descriptive study designs that we have already know is case report study design. If individual study subjects are involved, so that will be case report, case series, and cross-sectional survey. Could be under the category of descriptive study designs. If a population is considered as a study subject, ecological or correlational study design will be the type. So let's have just some examples for case reports and case series. And as you know, case reports are descriptions of individual cases of disease. And be sure that a single individual clinical profile will be reported in detail, but the disease should be unusual occurrence of a disease or unusual side effect of a drug. If a single patient with having sign symptom of possible malaria diagnosis comes to a hospital, That cannot be taken as a case report, A case report is considered if and only if the condition under investigation is unusual occurrence of a disease, a new occurrence of a disease, or a new side effect of a drug. That will be taken as a case report. But case series is a description of a group of individuals having the same sign symptom, coming specifically from the same geographical area. So that, the description of a group of individuals or patients coming from a specific geographical location with the same sign and symptom with unusual occurrence of a disease or unusual side effect of a drug. So that a case series will be just used as identification of initiation of an epidemic from a certain geographical area. So case series will be used as a first clue in the identification of initiation of epidemics. But case report will be used as a first clue in the identification of new occurrence of a disease or new side effect of a drug. So this is a very important. For example, if you take COVID-19, which occurred in China during 2019 Gregorian calendar, the first case that was found to be in China was very important, because in order to trace the source of the agent and in order to know the clinical signs and symptoms and in order to further investigate the way of transmission of the disease so as to develop preventive measures, So that was really very fundamental. So a new occurrence of a disease is very fundamental in case report and in case series. So both types of study designs are useful because they may generate hypotheses for further epidemiological investigation. So the findings obtained from case report and case series will be used for generating a hypothesis. That means a possible cause and effect relationship hypothesis will be formulated based on the results of case report and case series. So then after further advanced analytical epidemiological study designs could be conducted. So strongly suggestive anecdotal or clinical observations may indicate a possible causal relationship. So based on such clinical observations, hypotheses could be developed, So analytical epidemiological studies can then be designed to verify and to quantify the risk and to determine the role of confounding factors. So case reports may be used to track toxicity reports of new drug or foods, especially processed foods produced from different factors, Thank you. So case reports may be used to track toxicity reports of new drug or maybe food products, And especially food products are more of very common in every supermarkets and with pharmacies, So for the follow-up of toxicity of different drugs and foods, case report and case series are very applicable. Very applicable. And they are used as a first clue in the identification of new adverse effect of an exposure, whether it is a food type or a drug, whatever. Case series may be used to identify in the beginning or presence of an epidemic. So a case series is of greater value than a case report because the series provides more documentation of evidence for the suggested hypothesis. I think someone has a script to join maybe. Okay. So case reports and case series are a type of descriptive epidemiology study frequently evaluated by the Food and Drug Administration, Center for Food Safety and Applied Nutrition, This is very applicable and for the FDAs, very common. So there are two principal avenues through which case reports come to this attention. Maybe reports published in the peer-reviewed medical journal, and reports captured in one or more of the CFN's ongoing voluntary adverse event monitoring system. There are websites in order to report, So in either of the two methods, these types of occurrence of case reports and case series could be reported, you can read the detail actually. This is an example. Yeah, this is just an example to show you how applicable case report and case series is. So in the hierarchy of epidemiological study designs, the case report or the anecdotes is at the bottom line, the lowest in hierarchy of evidence, and the cheapest. The cheapest in terms of cost and time, but the lowest in terms of evidence. Okay, case report, as I have said, is just accumulation or maybe description of a group of individuals with the same sign and symptom, An example is given over here, the normal plasma cholesterol in an 88-year-old man who eats 25 eggs per day, This has been published in a journal in 1991. Imagine the person is 88-year-old man and he's eating 25 eggs per day, daily, Daily he is eating 25 eggs per day. But when the plasma cholesterol level was checked, it was found to be in the normal range. That was an exceptional case. Another example, in 1961, a published case report of a 40-year-old woman who developed pulmonary embolism after starting use of oral contraceptive use. That was the first time to detect OCP is having a side effect for developing pulmonary embolism, Such a case report was published in 1961. And another example for a case report is, this is a sad history again. This is a sad history. I will come back to this example. Let me show when the HIV/AIDS was discovered for the first time, When HIV was discovered in 1983 in America for the first time, because 5 individuals who were homosexuals coming with PCP sign and symptom, they were suspected for sexually transmitted disease. And actually the history shows us that such types of homosexual individuals having the same sign and symptom was first observed in England, but that was ignored at the time. When it occurs for the second time in America, it was considered for investigation. And that was the time for the first time to investigate HIV/AIDS in 1983 in America. But at the time of the discovery of HIV/AIDS, what was assumed was that HIV was assumed to be transmitted sexually. The only way of transmission for HIV/AIDS was assumed to be sexual route. But this example, as I've placed in this slide, the example 2 shows us that there was a condition or an opportunity, even though the history was sad, a condition which was an opportunity to know that HIV/AIDS was found to be transmitted through blood contacts other than sexual route, So the history tells us that this occurred immunodeficiency in an infant, a possible transmission by means of blood products. Before this time, it was not known that HIV could be transmitted by blood products or donation. In April 1983, it had not yet been shown that AIDS could be transmitted by blood or blood products when HIV/AIDS was discovered for the first time. But an infant born with Rh incompatibility required blood products from 18 donors over 8 weeks and subsequently developed unusual recurrent infections with opportunistic agents such as Candida. And the infant's T cell count was low, suggesting AIDS. There was no family history of immunodeficiency. When physicians investigated the history of the infant, both the parents of the infant were free from HIV/AIDS. But when they traced the blood products and the history of the donors of the blood, one of the blood donors was found to have died of HIV/AIDS. So this lead to the investigation to hypothesize that AIDS could be transmitted by blood transfusion, even though the history was sad for the infant. So the infant is, you know, life-saving for us, even though he has died of HIV/AIDS with blood transfusion. Because by having a knowledge of HIV/AIDS could be transmitted by blood transfusion, we are saved from HIV/AIDS by blood transfusion. Because of the infant he paid for us. You see, so this was the time when HIV/AIDS was found to be transmitted by blood transfusion. That is a case report, an example of a case report. You see, science is accumulation actually. We know, nowadays we are boosting. We know, I know this one, but science is just an accumulation with such an accident, you know. And the knowledge that we are boosting is not the one that could not be used as a boosting, you know. The knowledge that we know is not that much amazing. The knowledge that we know is just produced with such an accident most of the time. And the knowledge that has been written in any of the textbooks is accumulation of findings throughout different or long period of time. Okay, so this is an example for a case report, and then let's proceed with case series. And case series is next to a case report in terms of hierarchy of evidence. So the evidence will increase from the case report to the case series, and then to the ecological, and then to the cross-sectional, to the case control, to the retrospective cohort, prospective cohort, and then experimental study designs. So the evidence in terms of hierarchy will be just increasing in such a way. So a case series example is, as I have said before, discovery of HIV/AIDS in the United States during 1980 to that of 81. Four previously healthy young men were diagnosed with PCP, unusual opportunistic infections that had only been seen in immunocompromised people with hereditary disease at the time of investigation, or in people with immunocompromised due to maybe chemotherapy. That is what is known at that time, you know. The medical history didn't suggest any pre-existing immunodeficiency among these individuals, but all four men had decreased immunoresponses and low T4 counts. So this unusual infection suggested the possibility of a previously unknown disease. That previously unknown disease was occurred in England. It was noted that all four men were sexually active homosexuals. And the case series, which was published in the New England Journal of Medicine, the authors speculated that the immune dysfunction was due to a sexually transmitted infectious agent, but was not known at the time in England. But in United States, this was known that it is HIV/AIDS, the sexually transmitted infectious agent. So this is an example of case series because the common sign symptom has occurred in four males. There are four individuals. They are males in sex, they are homosexuals, they present with the same sign symptom. And then that is an example of a case series. And then the more advanced and more complicated clinical knowledge about HIV disease is written in different textbooks then after. And a number of treatment options, a number of guidelines have been developed, you know, starting from this output. Okay. So this was an extraordinary important case series, a detailed description of characteristics of a series of people who all have the same disease. That suggests that this nude syndrome was associated with sexually active in male homosexuals. Alerting the medical establishment and proposing a hypothesis was an important milestone in the AIDS epidemic. Another example of a case series is, I think you are familiar with phocomelia, that is severe malformation of the extremities. in offsprings of mothers receiving the drug thalidomide. And this is actually out of the market today, starting from 1961. The drug thalidomide was really at that time was found to be effective and the standard treatment for morning sickness for pregnant women. But in Australia, and actually there was an occasion of phocomelia in England, but that was rejected by medical managers at the time because the drug was very effective. But the only country who did not allow to use the drug thalidomide was America. The drug thalidomide was not introduced into America. That was not allowed to be used by American people, you know. But other than America, in every corner of the world, the drug was distributed. But after rejection of a case of phocomelia in England, for the second time in Australia in 1961, another obstetrician also found similar malformation of extremities in pregnant women in giving their births, you know. And then that was the time to investigate whether the drug was responsible for this phocomelia. And then it was confirmed that the drug thalidomide was the cause for phocomelia, and then it was out of market. So this is an example of case series again. And there is an additional example you can read from the PowerPoint. Now, the application of case series and report, useful for recognition of a new disease, as I have said before. They are useful again for constructing the natural history of a disease. And actually, studying the natural history of the disease is only possible at the initiation of new disease, before we develop any preventive or treatment agent. But if there is already a treatment or preventive measure, we cannot withhold a treatment. But if there is no treatment for the newly occurring disease, since there is no drug for the disease, you can study the natural history of the disease. Okay. Plus, they can be used to know manifestation of a new disease. They can be used to formulate hypotheses, and they can be used to detect an epidemic, if that is a case series, or to detect a new occurrence or a new occurrence of a disease, if that is a case report. But the disadvantage of case report and case series is that they are unable to test a hypothesis, you know. They are unable to test whether there is an association between a factor with that of the disease. And it is difficult because there is no comparison group in the case of case series and case report. So we cannot do any measure of association. And it is difficult to test for hypothesis because there is no relevant comparison group. And rates cannot be calculated since the population corresponding to the source of the cases cannot be well defined. We cannot know the source population from which the cases are drawn. So we cannot calculate the ratio of the cases to the total population because the source population cannot be known for the cases. So we cannot calculate the rates. And lastly, the most important fallacy is studies are more prone to atomistic fallacy. Cannot be inferred to the population. If you infer the finding from individuals, that means from a finding of a case report and a case series, if you infer the result obtained from a case series or a case report to the general population, that will be atomistic fallacy, which is the opposite of ecological fallacy that we have already learned. So now let me show you an example. Atomistic fallacy is the fallacy of drawing inferences regarding variability across units, defined at a higher level based on data collected from at the lower level. The data obtained from the case report or the case series, if you use this data to conclude at the larger population level, so that will be a wrong conclusion. That is said to be atomistic fallacy. The atomistic fallacy arises because associations between two variables at the individual level may differ from association between analogous variables at the population level. Now let's have a look at, for example, this example. A study of individuals may find that increasing individual level income is associated with decreased coronary heart disease mortality. That is at the individual level. That means increasing individual level income is associated with what? Decreasing CHD mortality. That is the individual level finding. But this association might be to the opposite at the population level. Let me proceed with the next slide. If it is inferred from this data that at the country level, that is at the population level, increasing per capita income is associated with decreasing CHD mortality, the researcher is committing or introducing atomistic fallacy. Because across countries or at the country level, increasing per capita may be actually associated with increasing CHD mortality. You see? The reverse. At the individual level, if increased income level is decrease the CHD mortality, but at the country level, increased per capita income may be associated with increased CHD mortality. So that atomistic fallacy will be introduced. The reality at the country level is increased per capita income is associated with increased CHD mortality. But at the individual level, maybe with using a case report or a case series. At the individual level is the finding could be the opposite. Increasing income level of the individual is associated with decreased CHD mortality. But at the country level, increased per capita income is associated with increased CHD mortality. So that we cannot infer the finding which is obtained from at the individual level to the finding at the population level. If you do that we are introducing atomistic fallacy. The fallacy is that in reality, at the population level, the increased per capita is associated with increased CHD mortality. But your inference is saying that increased per capita is associated with decreased CHD mortality, which is the opposite of the reality. That is the fallacy. So that is the limitation of case report and case series. That is said to be atomistic fallacy. That is the opposite of ecological fallacy. Again, someone is asking, Kalab, I think, or Kalab, sorry. So I think atomistic fallacy is clear for you. Now let's proceed with most important and the more of advanced one relative to the case series and the case report. The ecological study design or the correlational study design.